It's been a tradition of this meeting that when possible we start with the patient, because that's what we're all here to help and really understand, the core values and hear people's stories and then learn and appreciate that. And this year we've got something very unique for GCOS, which is, to my knowledge, the first patient who is also a medical doctor and therefore has seen it from both sides, as we all have through our training and delivering care, but then being the patient and being on the other side. So it's a real privilege to invite Dr. Alexia Oliver to come and open GCOS 2025 with her opening talk and share her experience with us.
Good morning, everyone. And thank you so much to Alex for the beautiful welcome. And welcome to Cape Town. And thank you to Cape Town for the slightly cold welcome. As you can see, I am Dr. Alexia Oliver. And I'd like to start by saying thank you so much to COSOSA for offering me the opportunity to share my story with all of you, with this esteemed audience. It is honestly an honor to be here. I'm currently a community service medical officer at Charlotte Macleod Johannesburg Academic Hospital. And I have given this talk once or twice before, almost to quite a few of you in this audience, but I have never actually spoken to this many degrees and this many publications in one room. So please bear with me while I hang on to my iPad and occasionally read my own words, because this is 100 times more scary than presenting on any grand ward round. I have constructed this talk in so many ways, from a purely biomedical presentation on my diagnoses, the complications that have since arisen, and to a more empathic discussion of my experiences as a patient. But today I am acutely aware that this room is filled with so many more esteemed professionals who are way more experienced at presenting curious cases such as my own. So I'm just going to share my story of both ends at the stethoscope. I don't plan on giving you a death by PowerPoint clinical presentation, but every good story does begin by capturing the audience's curiosity. And since, after all, we are in the presence of great academia, allow me to begin by sharing my diagnoses. Some people have CVs. I have a problem list. I am a cancer survivor, a chronic heart failure thriver, and the proud owner of bilateral total hip replacements. And I am also the lucky survivor of a rare stroke, a cerebral venous sinus thrombosis that was complicated by raised intracranial pressure and encephalitis. And I am by no means a professional orator, so please bear with me while I get comfortable. As is true for most of us here, for as long as I can remember, I have wanted to be a doctor. This aspiration evolved throughout my life, with the earliest being a singing, dancing, and acting dancer, to a more recent version of wanting to walk to HR after a particularly heartbreaking call and become an unemployed doctor. And now to my most favorite version of just being a good, thorough, and caring doctor. And after a high school career of 1 million extramural activities, I was accepted to Wits Medical School, and I began the more tangible journey towards becoming Dr. Oliver. And in 2018, I was in my final year of med school. I was completing my gynae rotation at Chris Hani Baragwanath Academic Hospital. I was attending tutorials, studying and learning how to tolerate sleep deprivation for the first time. I was exhausted, but no more than any final year medical student should be. I was losing weight, but I was surviving on muckers and scrub pocket snacks. And I was sweaty and itchy, but the combination of the broken theatre air conditioning and plastic aprons in obstetric theatres were the perfect recipe for perspiration. I remember this time so distinctly. I was meant to be studying for my 6th year obs and gynae exams, but I was just so tired. It was only when I noticed my face beginning to swell, that the veins in my neck were more obvious than usual, when I developed bruising across both my chest and arms, that I suspected something may be amiss. However, it took my head swelling up to the size of a watermelon, debilitating migraines, severe dyspnea, dysphagia, and chest pain before I acted on my symptoms. And to be completely honest, I only did so because I was not a fan of the severe facial edema and the fact that I looked like a member of our famous rugby team, the Booker, from the waist up. If it were up to me, I would have just stayed in bed because I was so tired. But I'm so lucky that I had my mother, my incredible mum who booked appointments, drove me to different doctors from maxillofacial surgeons to ENTs in search of a reason behind my vague symptoms. And after multiple appointments with a variation of healthcare professionals and diagnoses ranging from anxiety to acute otitis media, I managed to get an appointment with a physician who immediately admitted me to a high care ward and ordered a collection of urgent investigations. One of them being a simple chest x-ray, which was followed by a CT chest. And I've often reflected on this moment and the words that came from my physician, which would inevitably alter the way in which I experience life. Alexia, there is a mass in your chest, and it is most likely cancer. To be honest, it did not come as a shock. I was so sick that I'm not sure I had much left in me for a reaction. At the time of diagnosis, I had superior vena cava syndrome, thoracic outlet syndrome, a rare combo, a pericardial effusion, a jugular DVT extending into my right atrium, and a mediastinal tumor of about 14 centimeters in diameter, and subsequently a threatened airway. Upon further investigation, I had both cervical and para-aortic lymphadenopathy, and I remained in hospital for the next 37 days. During this time, I underwent a mediastinoscopy and received the formal diagnosis of primary mediastinal B-cell lymphoma, a subtype of non-Hodgkin's lymphoma. My first cycle of chemotherapy was infused during that 37-day admission, and because I clearly have a taste for the dramatics, I developed all sorts of side effects, including tumor lysis syndrome. My physician very kindly nicknamed me Jabba, as in Jabba the Hutt. And this was merely the beginning of my weird and wonderful reactions to R-CHOP. I was not a candidate for a port or any form of upper limb line placement, and I ended up with numerous femoral central lines. But I will never forget the first discharge day, that I left the hospital on wobbly cachexia legs, with the worst case of moon face thanks to my enormous steroid consumption, with little bald patches and leaving stray hairs on everything because I hadn't quite come to terms with shaving my head. That was quite tough. However, the hardest bit was coming to the realization that I would have to deregister from my final year of med school in order to endure another 7 cycles of inpatient chemo. It became even more difficult witnessing my classmates graduate from med school while I lay in bed counting my white blood cells on one hand, thanks to my neutropenia. I was trapped in this endless cycle of inpatient chemotherapy, hospital admissions with drugs like adriamycin, prednisone, Zoffa, and lorazepam becoming part of my everyday vocabulary. It was hard, but I never lost hope. And I'm not sure if that was the naivety in me or the medical student in me that then went and researched every single aspect of B-cell lymphomas and their excellent response to treatment. But I was convinced that I would return to baseline and medical school in a matter of months. And so I completed 8 cycles of inpatient R-CHOP, with my admissions varying between 4 days and 2 weeks, and my entertainment lay in my previously heinous textbooks, with Kumar and Clark and Harrison's becoming my comfort reads. And thanks to my frequent consumption of lorazepam, I could read the Cardio-Oncology chapter multiple times, as if it were all brand new. At the end of 2018, with only a simple post-treatment PET-CT scan standing between me and my triumphant return to medical school, I was faced with what was possibly my least favorite side effect of adriamycin. It started with a shortness of breath that I dutifully ignored, which then evolved to an audible rattle on exhaling, sleeping on 4 pillows at night, and developing the worst case of cankles. After a distressed call to my physician, I was swiftly taken to my cardiologist and diagnosed with a chemotherapy-related cardiomyopathy that was complicated by biventricular heart failure, the etiology of which had been my life-saving cardiotoxic anthracycline. And thus began the even more terrifying phase of my patient experience, an admission to the cardiothoracic ICU even more central lines, double inotropes, invasive monitoring, discussions about starting ECMO, and a workup for a heart transplant. I cannot quite describe the feeling of being in florid heart failure, but it is like drowning on dry land. When I allow myself to reflect, I think it was only then that I was scared. It was in that cardiac ICU that I realized the fragility of my own life. The only obstacle that loomed between me and a heart transplant was the fact that I hadn't had an NAD scan, and as we know, active cancer is a contraindication for transplant. After regaining some level of awareness in that CT ICU and waiting to become stable enough for my decision-making PET CT scan and being thoroughly assessed by the transplant team, I stumbled across a quotation by Dr. Viktor Frankl. "What is to give light must endure burning." I am not a philosopher by any stretch, but during my more conscious hours in that ICU, I realized that this was the burning, and I still had so much light. I harnessed the love that I had for my family, the need to be free of the constant beeping of monitors, and my genuine desperation to become a doctor, and I focused every tiny atom on trying to live. And somewhere between the delayed PET scan, the fluid diuresis, the magical dobutamine, and an excellent ICU team, and my general stubborn mindset, my ejection fraction began to improve from a miserable 12% to a much more pleasing 20%. I was weaned from my inotropes, taken off the active transplant list, and discharged from that ICU with more appreciation for fresh air than ever. And a couple of weeks later, I had my first NAD PET CT scan, and this provided some sorely needed reprieve, not only for myself, but for my loved ones, and for my family, and for my physicians, who I think were becoming a little bit tired of seeing me on the weekend. The relief was immense, and was shortly followed by my planning to get back to medical school. I made a tentative goal to return to med school in February 2019, exactly a year after I was diagnosed with lymphoma. However, cancer and heart failure at age 23 are only two conditions on that very long list of primary minimum benefits on the medical aid, and I felt the need to gain more first-hand experience of other PMVs. While committing myself to my cardiac rehab, taking gentle walks where I could, and trying my utmost best to reach a New York Heart Association Class 2, I started to experience some hip pain, and obviously, I did my best to ignore it. However, pain is persistent, and pain demands to be felt, and when I could no longer sleep at night or put on my own socks, I relented, and off I went to the doctor. And a series of x-rays and a rather loud anxiety-inducing MRI revealed that my bestie, R-CHOP, did not only betray my heart, but snuck around to my hips too, and I was diagnosed with bilateral grade 3 avascular necrosis of my femoral heads. This diagnosis opened up an entirely new chapter in my oncological journey: more hospital stays, 2 failed core decompressions and bone grafts, a parathyroidectomy and a resulting partial thyroidectomy, and 7 months in a wheelchair, completely non-weight bearing. And let me tell you, those 7 months gave me more empathy than I knew was possible. And after what felt like decades of pain, immobility, and the complete loss of my independence, I was gifted 2 new hips, 2 fancy titanium and ceramic joints that allow me to walk around the garden, to make my heart a little stronger, and to start driving again after 2 years. And, most importantly, to get back to medical school. In January 2020, after 1 cancer diagnosis, 1 heart failure diagnosis, 2 years of medical treatment, 8 cycles of R-CHOP, 8 femoral central lines, 1 PICC line, 618 Clexane injections, and yes, I counted every single one, 2 failed bone grafts, 1 partial thyroidectomy, 2 successful total hip replacements, and a pharmacy of anti-heart failure medication. I went back to medical school. Unfortunately, due to my extended leave of absence, I started in 5th year instead of in final year as per university policy. It was a bitter pill to swallow at the time, having already passed 5th year before I was diagnosed, but at least I was well enough to go back. I will never forget the vulnerability of resuming my studies, a little bit older than everyone else, with a lot less hair, a crutch in one hand, and the need to sit down for every tutorial. And my first day back began with an allocation to the oncology ward, which was emotional, to say the least. In December 2021, I graduated from medical school as Dr. Alexia Oliver. 3 years later than expected, 3 years more tired, but 3 years more passionate and grateful than I ever would have been. I started my internship at Chris Hani Baraganath Academic Hospital in 2022. It was my first choice of internship. Those first 18 months were some of the most rewarding and heart-wrenching months of my life. I initially oscillated between patient and doctor multiple times, finding my unique perspective to be exhausting from all sides. My medical PTSD persisted in those first few months as Dr. Oliver. I avoided performing central lines as much as possible because just the smell of the plastic and the sound of that set being opened would send me into a spiral. I flinched at every monitor. I dreaded visiting ICU for consults, and I wanted to sob at every piece of bad news that needed to be shared. But after 18 months of being a Barra intern, I was no longer scared of central lines. I was learning how to use my unique position of being at both ends of the stethoscope to provide comprehensive care for my patients with humanity and empathy. And incidentally, this year was the first time I gave a talk at the Cardio-Oncology conference in Durban. But this is where I need to take a breath, because previously, at any other junction in my life, this is where I start to conclude. However, if the last few years have taught me anything, it's that once you start gathering diagnoses, you tend to be vulnerable to a few more. On the 30th of June, 2023, during my last case of my anesthesia block as an intern, the world went dark. I went from being a junior doctor performing a smoothly run elective sequence intubation to collapsing in theatre at work again, to being a patient requiring an urgent MRI again, and then having yet another prolonged hospital stay. I had had a cerebral venous sinus thrombosis that was complicated by raised intracranial pressure and encephalitis, and I'd had significant neurological fallout, expressive aphasia, although you'd never say, ataxia, and persisting diplopia, to name a few. My admission lasted for 62 days, and to be completely honest, I can't remember most of it. In an attempt to regain functionality, I started an intensive occupational speech and physiotherapy program. I took 9 months of incapacity leave from work and watched as my colleagues completed their internships and started their community service posts. While they were studying for specialist exams, my occupational therapists and I were teaching my hands how to hold a pen. But in April 2024, after a rigorous amount of outpatient therapy, I returned to work to complete my remaining months of internship. And to this day, I'm not quite sure how. I am exceptionally grateful to every single member of my multidisciplinary team who ensured I would be fit to return to work as a competent intern. And I completed my internship last year, a goal that I'd had since starting medical school and a goal that I have pursued throughout everything. I am now deeply grateful to be 10 months into my community service year at Charlotte Macleay Johannesburg Academic Hospital, where I've had the privilege of spending most of my time in pediatrics. It has been a season of immense growth. I've learned so much more than I could ever have imagined, both as a doctor and as a person, and I've been stretched far beyond what I once thought I was capable. After sharing my story, I'm always asked quite similar questions. The bankers tend to ask me about my workplace, about how forgiving my departments were, about income protection. The insurance crowd favor the medical aid-related questions, and the professors quiz me on pathology. But the hardest questions come from those who ask why. Why I chose to continue pursuing medicine despite having so many opportunities to step away. And to that, I answer with a quotation that has gently encouraged me through every single adversity, whether it has been my cancer diagnosis or just a particularly difficult day working in a pediatric ICU. Once again, by Dr. Viktor Frankl. Those who have a why to live can bear with almost any how. I have experienced so many different versions of hows, and not only the ones from the vantage of the hospital bed, but also from standing at the foot of it. As healthcare workers, our career path is tainted with burnout and compassion fatigue. We are exhausted and our resources here are so limited. It's really hard to optimize care, especially for oncology patients, especially at an overwhelmed junior doctor level. And as a proud cardio-oncology patient myself, I know we slip through the gaps, even when we have access to exceptional care. So please, from this very junior medical neonate, allow me to ask you to remind yourselves of the why behind this field, to keep your knowledge and your experience as accessible as your stethoscope, but to keep your empathy just as accessible in that little scrub pocket that's over your heart. Over the last few years, I've realized that the heart, in every sense, is astonishingly resilient. It remodels, it recovers, and it somehow continues to beat even after profound injury. So as we continue advancing the science of cardio-oncology, I hope we never lose sight of the art, and that we keep our empathy as close as our stethoscopes and our humanity as steady as a normal sinus rhythm. I have so much learning to do about myself, about medicine, about pathology, and about providing comprehensive healthcare, especially in our South African context. But I know that with multidisciplinary collaboration and innovation, the future Alexias may have access to even better care than I did. And I truly cannot wait to watch that unfold as both the patient and the doctor. I have realized that medicine is miraculous, and that medicine combined with tenacity is a truly incredible combination. But medicine combined with tenacity and humanity could be invincible. Thank you.